I think actually the AACR data clearly support the concept that now we have a new standard of care in the first-line treatment of hormone receptor positive, HER2-negative advanced breast cancer patients, because the data, once again, they support the concept of combination therapy, endocrine therapy plus CDK4/6 inhibitors in the first-line treatment setting. We may have some situations, we have seen some interesting data at the AACR suggesting that perhaps in some patients with a less clinically aggressive disease, you may potentially start with single-agent endocrine therapy. But I think in a few lines, the bottom line message is that the combination therapy, endocrine therapy plus CDK4/6 is going to be the new standard of care for the first-line treatment of this particular group of patients. I think this is indeed a very good point. Actually, the data suggests that the three CDK4/6 inhibitors are very similar in terms of activity. There is a difference in safety profile. We have more myelodepression with ribociclib and palbociclib. We have less myelodepression with abemaciclib, but abemaciclib is associated with more GI side effects than ribo and palbo. So probably this is the only main difference, and so I think that the tailoring of the treatment should be based on individual patient characteristics. You may have patients where diarrhea may be more dangerous, you may have patients where myelodepression may be a problem, so I think this is exactly the way we should tailor the treatment. Activity seems to be extremely similar. Good point. You said current clinical world. Unfortunately, current biomarker research is not yet there. So, I mean, we have a lot of research ongoing worldwide about an attempt to discover new biomarkers that could potentially identify patients deriving the largest benefit from this type of treatment. But unfortunately, so far, we are not yet there. We have seen interesting data at AACR that may potentially suggest that in the future we will be able to tailor the treatment based on disease biology. But honestly, nowadays, I would not recommend any specific biomarker for taking decisions for our daily clinical practice. It will come, but it's not yet there. I think it was a good meeting. We had interesting data in different fields of the advanced breast cancer research and therapeutic area. For instance, CDK4/6 inhibitors, once again, they have been confirmed as active agents in combination with endocrine therapy, either in the first or in the second line, third line setting for metastatic disease. But we have seen, for instance, interesting other opportunities, like, for instance, the combination of a CDK4/6 inhibitor, such as ribociclib, with mTOR inhibitor and endocrine therapy. Interestingly, in this small provocative study, patients were already pre-treated with a CDK4/6 inhibitor. So the study may suggest that you potentially in the future may use a CDK4/6 inhibitor beyond progression to a prior treatment with CDK4/6 inhibitor. Of course, this was a phase 1b study, no randomization. By the way, it's hypothesis generating. The final results of the study suggest that there is some activity there, so it will be probably important to see what is going to happen when this study will go into a randomized setting. In triple-negative breast cancer, we have seen also interesting data. We had, for the first time, the survival data of the olaparib trial, that I think is also quite interesting. The data suggests that you may improve survival with olaparib in triple-negative breast cancer. Of course, this was not the primary endpoint of the study. The study was not powered to detect survival improvements, but by the way, the results are going into that direction. Well, I think that actually the data presented at AACR in terms of national or regional impact, they will probably consolidate the role of CDK4/6 inhibitors in standard practice, because actually we have clearly now 3 trials reported final analysis, and all of the 3 trials clearly showing the superiority of the combination therapy versus single agent, either in the first line setting or in patients who are resistant to endocrine therapy. So probably the main impact will be that these drugs will be fully approved and used in clinical practice because of the convincing results from these phase 3 trials that have been reported in the last couple of years, including the last update at the AACR 2018.